All right, I think we'll go ahead and get started here. Thank you all for joining us this morning for our first Contact Hour webinar that we have in this second cohort of our Opioid Guardianship Project. Today we'll be talking about the Prescription Monitoring Program. My name is Sarah Durr, and I'm the Medication Management Lead here at the Iowa Healthcare Collaborative. I also have Jennifer Kriegmer with me, and she is our Quality Improvement Advisor and the lead on our HIN portion of our Opioid Guardianship Project. Today, we just have a couple of housekeeping things that I'll go through, and then I'll let Randy get started, and I'll introduce Randy shortly here. So first, I wanted to show you all our updated map of our Opioid Guardianship Cohort number 2. You can see that we have 43 different hospitals involved in this cohort, and that includes some in South Dakota. So we're very excited to have as many as we do, and we're very thankful for all who are participating in this project. So just for your information today, we are offering nursing contact hours. You must be logged in for the entire call from the time that we started at 11 o'clock until we finish between 12 and 12:30 in order to receive credit. Credit will only be given during the designated call time, so we cannot offer this later on with our recording. For those of you that are not nurses or seeking contact hours, we will have a certificate of attendance sent out to all healthcare professionals, and you will receive that in about a week or two from today's webinar. If you do have a question during this time, please feel free to use the chat box and ask your question during the webinar. We will address all questions at the end of the presentation. And if you do want to unmute your line, please feel free to put in the chat box that you would like to discuss with the group, and we will unmute your line so you can share that information with us. So with that, I am happy to introduce Randy McDonough. Randy McDonough is the co-owner of Towncrest and Towncrest Compounding Pharmacies in Iowa City and Solon Towncrest Pharmacy in Solon. He is a partner in Innovative Pharmacy Solutions, a consulting and clinical documentation software company. He helps foster collaborative working relationships with solo and group physician practices in immunizations, anticoagulation, disease state management, and medication therapy management services, and was instrumental in implementing MTM services for the Iowa Medicaid Pharmaceutical Case Management Program. Dr. McDonough received his degree from the University of Iowa College of Pharmacy, where he is also an adjunct professor. Welcome, Dr. McDonough. We're very excited to have you present on this topic.
Thanks, Sarah. I appreciate that. The way I always like to start my presentations is start with a story, so we understand the significance of this program and the significance of the opioid epidemic and the need for important tools that we have access to, including the prescription monitoring plan. But this happened, this particular patient situation or case happened in both December and in January. So in December, on a Saturday, and as I always tell people during these presentations, it's usually after hours during the week or late Friday evening or Friday afternoon or on a Saturday morning when access to other providers is going to be limited. And that's when I think obviously individuals know when they might be able to, pull a fast one on trying to get a fraudulent prescription filled. But in this particular situation, it was actually another healthcare provider. It was a physician. And this physician had come in on a Saturday morning, and they had a prescription that was handwritten for a narcotic, and it was for pain that this individual indicated was for her mother. We did our due diligence and went through all the processes and procedures that we use to ensure that this was legitimate, including asking her for her identification and clarification and knowing who she was. Even in that situation, we still had some red flags that we felt, but at the end, we didn't have enough evidence to say that this was not legitimate. So we went ahead and filled the prescription. And then on Monday, so that was on a Saturday, on Monday, then all of a sudden alert gets posted in the PMP and with this person's name on it, and to inform us not to fill any prescriptions that this person may be trying to fill. So we learned our lesson, except that now that this is in the system, and not only pharmacists, but other physicians and providers can see this information, this patient comes back in January, so not that long ago, and comes back not on a Saturday, but actually during normal working days. And we were alerted about this individual because the information that was in the PMP it was alerted to us from another pharmacy that they had tried to fill this prescription at the pharmacy. So we were on high alert, and sure enough, the person comes in and wants to get the prescription filled. So we were ready, and at that point, we were ready to call the police and try to get this person, and hopefully arrested, but long term get this person the help that they need. And the police did come. It took about a half hour, so that's a whole nother story about, what do we do to protect our not only our other employees and keep them safe during this time, because you just don't know what someone might do, but also protecting our patients because it was right during the middle of a very busy time. But long story short, this person was arrested, and so hopefully this person now gets in and gets some real help that they need. So this is occurring on a regular basis, and it's occurring not just with our everyday patients, but also with other healthcare providers who may become addicted. Another situation that happened in our pharmacy, again, just to really expel the epidemic and the abuse that's occurring out there, we had a mother come in. She had a 5-year-old daughter with her, and she wanted to get some needles or insulin syringes filled, and she didn't have a prescription, but she said it was an emergency because it was for her grandmother who takes insulin, and they just were out of it, and we couldn't figure out what was going on, but we did have a 10-pack of syringes that we could give to her for the short term if that really was an emergent situation. Person ended up going into the bathroom, taking her daughter with her. We noticed that she was in there for an exorbitant amount of time. When she came out, she looked very glassy-eyed and was not herself. And then at that point, we became concerned. We went into the bathroom, and sure enough, it looked like she had cooked a substance that on our porcelain toilet, and she had actually injected some heroin when she was in the bathroom. And we called the police, and she got busted at a business that was located by us. So again, some of the things that you don't expect are going to happen within your practice happen. So the objective of this presentation today is review the guidelines for appropriate prescribing of opioid medications. We're going to be reviewing the CDC recommendations that came out in March of 2016. We'll discuss addiction risk associated with the use of opioids, review proper record keeping for opioid prescribing, but also from a pharmacy perspective, what we need to be doing to be monitoring and documenting our data with our patients. We want to discuss the benefits and challenges using the prescription monitoring plan, and then also demonstrate how to access it, how to register for the PMP, and also how to delegate access to an agent looking up a patient. Next slide, please. So we're going to spend a little bit of time here talking about guidelines for opioid therapy. As I mentioned, these were published in March of 2016. So why did the CDC come out with this? Well, if you actually go into the report, you start seeing some of the statistics that the CDC was looking at when they actually developed these new guidelines. One of the first stats that you see is that 20% of patients who are presenting to a physician office with non-cancer pain symptoms or pain-related diagnosis received an opioid prescription. So there's a large number of prescriptions being written for patients. And in 2012, healthcare providers wrote over 200 million prescriptions for opioid pain medications, which was enough for every adult in the U.S. to have a bottle of pills, containing opioids. And that statistic will come up again when we go to a later slide in 2016, that we really have not changed. Also, they saw that opioid prescribing increased by 7.3% between 2007 and 2012, with opioid prescribing rates increasing more for the primary care providers as compared to other specialties. So that is something that was a concern as well too. But one of the things I really want to make clear too, as we look at the statistics that the CDC looked at, also from our perspective, my generation, and I graduated in 1987 with my BS, and then 3 years later with my master's, and a couple of years after that with my PharmD. But during the time that I was being trained in the 1980s, we were taught that we were not treating aggressive enough. And so we felt like we needed to do a better job. Plus, we were taught that if the patient really has pain, they cannot become addicted, which now we know is not true. Next slide, please. So if we look at the CDC recommendations, we'll go through each one. The first one is that opioids are not first-line therapy and really only should prescribe opioids so the benefits outweigh the risks. If opioids are used, we need to really combine them with non-pharmacologic therapy and also non-opioid pharmacologic therapy. And the non-pharmacologic would include making sure the patient's just active, doing aerobic activities, utilizing resistant exercises, but also cognitive behavioral therapy as well too. As we look at other therapies that the patient could be using, again, some of the things that we think about is acetaminophen, nonsteroidal anti-inflammatories, but there's also select antidepressants, anticonvulsants that might be used for neuropathic pain. But again, we may see patients using combination of these with opioids, but hopefully at some point starting to taper off the opioid if possible. Also, we want to establish realistic goals for the patient and also make sure they understand the realistic goals for function and what they can expect for pain relief utilizing this. We need to work with the patients to really determine how effectiveness is going to be evaluated, make sure they understand that, and really understand the treatment goals. Again, as I mentioned, making sure they're realistic as far as, will I be pain-free, or is this just going to reduce the pain for me so that I can become more functional? We also want to discuss the patients with the risk benefits of the medication before starting it. What we have to remember is that patients lack the information about the risk of opioids. We are the experts. If we're the ones prescribing it and dispensing it and monitoring the patient, we have to make sure that we fully understand and are up to date with the data and make sure the patient fully understands. And as I tell my staff, it is our job to make sure that our patients are informed consumers about their therapy. So we have to make sure they understand the risks and benefits of that. One of the things I do want to mention is that if you really look at some of the clinical evidence that's out there right now, there's really insufficient evidence to determine long-term benefits of opioid therapy for chronic pain. And yet I see that on a regular basis within our practice. I see it as a consultant for a nursing home, how patients come in and they're on anywhere from low to moderate doses of opioids, and whenever we try to taper it, they just cannot taper off of it. Well, because we affected them in a different way. It's not so much the pain relief that they may be needing, but really some of the psychological and addictive things that have happened now that the patient has been on it and the changes that have occurred in their brain. So it's something we see on a regular basis, and it's just something that we need to be aware of. Next slide, please. When we look at using opioids, it's best to use the immediate release opioids when starting. There is a higher risk of overdose when using the extended release or the long-acting opioids, and there really is no evidence that the extended release or the long-acting opioids are more effective, nor do they really reduce the risk of opioid misuse or addiction. But there is a place for the use of long-acting opioids. So I don't want anybody to say that, okay, this person's saying you don't use it, but there are places where a patient has it, whether it be for legitimate diagnosis or for cancer pain, and the patient's taking opioids on a regular basis, where we need to give them more extended period of pain relief and only use the immediate relief for breakthrough pain, so we can reduce the bill burden for that patient. So that is something to realize, that there is a legitimate use for the long-acting ER dosage formulations. But we always want to start using the lowest effective dose. And whenever we do increase the dose, we want to reassess the risk and benefits for the patient. We want to avoid increasing dosages that are 90 morphine milliequivalents per day. And we want to carefully reassess the risk benefits if we're actually increasing the dose by 50 morphine milliequivalents per day. So we just want to make sure we're being deliberate when we make a dose increase, and we understand what the risk benefits are, and we make sure the patient is being monitored appropriately from that perspective. The next one is prescribing a short duration for acute pain. Again, we want to use the lowest effective dose in using the immediate release opioids. But obviously 3 days should be something that we look at, and usually we don't really need to go beyond that for an acute situation. Now, again, as I've talked to physicians and other healthcare providers, obviously there's going to be certain procedures, certain surgeries, certain things that the patient has been through for which they're going to need longer treatment. beyond just even a 7-day. But most importantly, what we need to understand is that we just need to be monitoring the patient. Yesterday, I had gone in for a consultation for oral surgery as I looked to get dental implants. And it was really interesting as I'm talking to the oral surgeon as we talk about what is the therapy that I will be receiving. And sure enough, not only with the chlorhexidine mouth rinse, but I'm also going to receive an antibiotic. I'm also going to receive ibuprofen, and I will also be receiving a hydrocodone acetaminophen prescription as well too. So without even asking if I have any problems with that or assessing, that's just going to be an automatic that I would receive that. So then the question is, what's the quantity that I will receive? And that's where I would say that no more than a 3-day supply should be prescribed for that patient, and having an understanding about how long this the pain and will occur. And he made it clear to me that usually within a day you may want to take the next day off from work, but after that you should be okay. So to me, we really don't need any more than 3 days. So that's something I'll be monitoring as I go through this procedure. And then we want to evaluate the benefits and harms frequently. We want to evaluate the patient within the first month of therapy, and then also whenever we increase the dose for that patient. Also, for those patients who are using it chronically, we need to do a better job of reviewing that patient on a regular basis. And that's where I'm seeing a lot of issues within our practice, for which we're going to the P&P, because it's kind of a gray area. Does the person seem to be using it more? Are they going to see multiple physicians? Are they going to multiple pharmacies? Or are they just getting it filled a lot here? And in one particular case, we had a patient for which there was some red flags that came up. And we actually sent a note to the physician, letting them know the concerns that we have. Luckily, the physician was very understanding, and now to this day, we send progress notes back and forth as we monitor this patient to make sure they're appropriately using the opioid therapy, and also working to reduce the dose of that for the patient over time. So this is where working collaboratively as a team becomes very important, and communicating on a regular basis so that we're having an effect on and helping our patients. Next slide, please. Next, we want to use strategies to mitigate risk. Obviously, those patients who may be at more risk of an overdose, whether they have a history of overdose or substance abuse, those patients might be good candidates for naloxone, making sure they have that on hand. Iowa is a state that has a standing order policy in place where certain pharmacies have been trained and have signed up. Will have access to naloxone and be able to provide that to patients as a standing order within the state. Also, we want to review prescription monitoring data. And I think that's probably one of my biggest things. We have this resource that's out there, but not all providers are using it, or at least not using it as effectively as they possibly can. So we want to review prescription monitoring data whenever starting opioid therapy for chronic pain. And we also want to review it periodically during opioid therapy, as I said. And I'd like to give another example of what happened. Last month, I had a patient that came in on a Saturday morning. It was actually the patient was a patient's friend. The medication was for an oxycodone prescription. It was for 1,000 cc's of oxycodone liquid. I didn't have any history about this patient, so my first thing was to talk to the person who was actually bringing the prescription, saying, you know what, I don't have a history with this patient and I'm not going to fill it. He gave me the story that the reason why he came to our pharmacy is because the pharmacy he was going to was closed today. They had informed him the day before that the insurance would not fill this until the next day. They could go in any pharmacy. So he was just really following the instructions of the pharmacy. I told him that I still would not fill it unless I could talk to a physician. So he encouraged me to go ahead and call the physician, for which I did not think I'd get a hold of anybody on a Saturday morning. Lo and behold, I called the clinic. I was able to get the physician who was actually at the clinic. I asked if they could review the record. The physician reviewed it and gave me the information. And basically it said that for this particular patient, they were concerned that they may be abusing and that may actually not even need it anymore. And this would be the last prescription. So obviously we've got a patient who is already starting down that path of trouble. And now we're just, going to be part of that problem, or are we going to do something to help? So at that point, I talked to the friend, said we're not going to fill it. I think he needs to be seen. Plus, when I did the P&P, I said he should, based upon the dose he was taking it, he should have plenty at home. Then he called the friend wanted to talk, or the actual patient wanted to talk to me. I talked to the patient, told him that he should still have enough of the oxycodone liquid and he should wait until Monday, talk to his physician about it. He said, well, I don't have enough, and the reason why I don't have enough is because the pharmacy I went to previously only had half the amount. Well, the PMP has about a 2-week lag, and so I told him that information wasn't even in the record, but I was basing upon the previous prescription before the last one that he filled, and that really made me say, you have plenty on hand then. And so at that point, the patient was not happy, was upset, asked me just to give the prescription back to his friend, which I did. Obviously, I had talked to the clinic already, let them know of our concerns, and hopefully, this person now is being titrated off, or tapered off the medication, or receiving appropriate help that they need if they are having problems. So these are things that are happening on a regular basis as well too. The next thing is urine drug testing. I know, talking to several physicians that I've presented to, they do urine drug testing. I did see that there was an alert that went out recently in the PMP of a patient who had urine drug testing done, and they could not find any evidence of the medication they're supposed to be taking. Patient said the reason why is because the pharmacy filled it wrong, which the pharmacy vehemently denied. And so again, there's some benefit to using urine drug testing just to make sure that our patients are actually taking the medications as they should. The problem with urine drug testing is it may not, and probably is not, going to be covered by insurance, and there could be an expense related to that as well too. We also want to avoid concurrent use of opioid and benzodiazepines. There is a safety concern that benzodiazepines can further depress the CNS, or central nervous system, and also can decrease the respiratory drive. If we can get the patient off of benzodiazepine before starting opioid therapy, that would be ideal. If we are going to get them off the benzodiazepine therapy, we can't just cold turkey it for that patient. And usually what we recommend is a taper of benzodiazepine of 25% reduction every 1 to 2 weeks until they're off the medication, just to make sure we're not increasing the medication safety risk for that patient who may be taking an opioid. If we actually do have a patient who has a problem that we've identified, then we got to make sure we refer them to the appropriate providers who can help them, especially the medication-assisted treatment. As we look at some of the new upgrades that's going to be in the PMP, there will be a new tool that will be there, which we'll talk about, which will help us to assist in referring patients, but also providing them with resources and tools if we identify them as a high-risk patient. Next slide, please. The next thing we're going to talk about is the opioid addiction risks. Next slide. So the reason why we believe we need to do something is because obviously we're seeing that there are more problems, more accidental deaths, overdoses associated with the use of opioids. So if we look at the first bullet, drug overdose is now the leading cause of death in the United States. It has actually surpassed motor vehicle accidents and gun deaths, which just happened in 2016. And then more than 6 out of 10 drug overdoses involves an opioid. More than 50,000 Americans died of a drug overdose in 2016. I was asked recently by a news channel and saying, do you think providers will become more at risk if they have actually prescribed and actually dispensed the medication? I think as healthcare providers, we're all feeling that extra burden. And I said, yeah, I do think that we have data that's in front of us. And obviously there's a big push to make sure that we're doing a better job of monitoring our patients, so that if we're not doing that appropriate monitoring, I do think the healthcare providers will become more at risk. And I think we're seeing some cases of that occurring, in today's world. 4 in 5 new heroin users start out misusing prescription painkillers. It's interesting, as we'll see a graph that comes up later, how opioids outpaced heroin users, but that's part of the reason is because of ease of access at one time of getting the opioids. Now that it's difficult to get opioids, plus the cost of therapy has increased over time, actually now you're seeing the increased use of heroin occurring again, and surpassing actually opioid use, because actually has easier access and not having as many problems. So now we've got a concern about that again. So we just have to make sure we're monitoring our patients appropriately. 91 Americans die of an opioid overdose every day. Again, whose responsibility is that? What do we need to do the appropriate monitoring? And from 1999 to 2010, the amount of opioids sold to pharmacies, hospitals, and doctors' offices has nearly quadrupled, which I can speak for myself. I know that we have seen that. We're also hospice pharmacies, so we do see end-of-life cares and cancer pain. So there's legitimate reasons, but yet there's no overall change in the amount of pain that the Americans report. So we have a lot of other patients who may not have cancer or who have end of life, and these patients are taking a lot of opioids and still not claiming they're having any pain relief. And in fact, they may be more hypersensitive to the pain and really are looking more for the effect it's having psychologically as they take the medication. Next slide, please. As many as 1 in 4 patients receiving prescription opioids long-term in a primary care setting will struggle with addiction. So we just have to make sure that our patients are being appropriately monitored. And this is a responsibility not only of the prescriber, but also of the pharmacist and other providers that's working with that patient. I told you the statistic that I already talked about from the CDC when they came out with their guidelines in 2016. We see that over 2016, over 214 million exactly were written for opioids, which I've mentioned already. That's enough for every adult in America to have a month's supply of opioids. So again, a lot of opioids being prescribed. Each day, 1,000 people are treated in the emergency department for not using a prescription opioid as directed. Recently in our paper, I saw the number of deaths associated with opioid use, and it was a lot of young people and people who got addicted to it because they were started on it legally and then ended up having an overdose because of that. So obviously this is a tremendous concern at this point. Next slide. I think what's also interesting as we look at these next 2 slides is just looking at prescribing rates for opioid therapy in Iowa and looking at our 99 counties. And in this particular slide, we see a lot of more of a light yellow or beige color, which is indicating that the rates are not as high. If we go to the next slide, we see that now there's more of a coloring of this state because now we're seeing that the prescription or prescribing rates for opioids has increased in our counties. And now we've got some more dark reds and some brown colors out there. And this is indicating a higher prescribing rate. So obviously during that decade, during that 10-year period, we're seeing an increased use and increased prescriptions of opioids for our patients, which is leading to some of the problems that we're seeing today as well too, as far as misuse of opioids. Next slide. I think what's interesting about this slide, as I already talked about, is you can see heroin, which is the blue mark, and how that has now surpassed. It's a much steeper curve, and part of the reason for that is because of some of the things we have done in more recent years to make it more difficult to get access to an opioid. And now that we have tools such as prescription monitoring plan, people are monitoring this more closely, so really preventing patients from abusing opioid therapy. But obviously the natural and semi-synthetic opioids, which are the most common things we think about, the natural are morphine and codeine, and the semi-synthetics include things such as hydrocodone, hydromorphone products. So those are still obviously a big issue, and these are the things that might lead people to using illegal medications as well too. As we look at synthetic opioids, we see that being on an increase. That would be like the fentanyl, meperidine. It does include methadone, but this is outside of methadone. So these are just things that are being abused beyond just methadone. So we look at again, as I said, fentanyl and also the meperidine. The other thing I think is important for you to realize too is, there are other medications, psychostimulants with abuse potential, and we're seeing that that's on the increase as well too. And that might be the methylphenidates and other stimulants that are used to help patients with ADHD or ADD, but just something for us to be aware about. Again, making sure the patient is being appropriately monitored. Next slide, please. If we look at the opioid crisis in Iowa, we see that from 2009 to 2014, there's been an 11% increase in opioid-related hospitalizations in Iowa. So obviously we know within our own state, we also saw the increase in the past 10 years with the opioid prescription rates. If we really look at the characteristics of the patient who's hospitalized for opioid-related reason in Iowa, it's usually a female, greater than 65 years of age, living in a metropolitan area and of low income. As I look at my patient population that comes into the nursing home and the patients who are on opioid therapy, again, I'll see both male and female, but I'll see a lot of women who have been put on opioid therapy, and then when we try to taper them off of it, we can't. And so now we've got an issue where we got an older patient who's been taking this for a long period of time. Family wants them to be on it because they realize the patient feels like they're suffering without it. Now we just, caused ourselves an issue of now can we get them off the medication? To this day, I still will make a recommendation to taper patients off and replace it with a non-opioid type of therapy. And but working with the physician and working with the family becomes absolutely important to make that successful. Next slide. If we look at record keeping and requirements for both the prescriber, but also for the pharmacist who's dispensing. Next slide. As I talked about that oxycodone patient earlier, I think it's because at least there was good documentation on the physician side, for which then I could add to my documentation on my side that there was a potential issue. Had that not occurred, had that documented note not been there, it could have been that I would have dispensed the medication after talking to the physician who was on call based upon the records that he had. So obviously having good records becomes essential to the appropriate management and monitoring of the patient. So if we look at the type of records we have to keep for all prescription drugs dispensed, we got to just make sure we got the name and address of the physician, the name of the patient, the date that the medication was dispensed, the directions, also any cautionary statements for the patient, and the name and the strength of the medication. So that's just by law what we have to have as our baseline information for dispensing a medication. Next slide. Then for medical record side, we would just want to make sure that the patient's record is clearly documented as far as the patient's medical history, their pain history, the clinical examination, the diagnosis, the treatment plan, especially if we're going to be putting them on an opioid. What is the treatment plan? What's the goals of therapy? Has the patient been discussed with the risk benefits? Have we made them an informed consumer of their health care? Physicians shall keep accurate, timely, and complete record of discussing the risk benefits of using controlled substances with the patient, including the number of bullets that we have listed there, making sure the patient is informed, that they even signed off on informed consent, that we're doing a periodic review of the patient, and that we're doing a consultation with the patient. Also, this might be a good time to let the patient know that there may be communication with other providers, including with the pharmacy and vice versa. And that might be a place where the patient may need to sign off on a release of medical information. I know we will do that in the pharmacy as well too, if we're working with the patient to monitor them, just to make sure that we know data can flow freely between the providers. Next slide. The next section we want to focus in now is the prescription monitoring program, and really understand the ease of its use and the importance of using it on a regular basis, because if we can identify a problem before it becomes a problem, then we're in an ideal situation. But again, if we're not utilizing this as effectively and as efficiently and as comprehensively as we should, it's going to run into problems of which we all can attest to on a day-to-day basis when we run into issues because one of the providers in that chain of providers did not do the check, and then that puts the burden on the next provider to say what's the next step, which causes further burden within the system because they're probably calling the original prescriber and saying, here's the issue that we have, what do you know? And so I think the more we could be proactive looking at these records, the better off that we'll be. Next slide. According to the National Alliance for Model State Drug Laws, the PMP, or Prescription Monitoring Program, is a statewide electronic database which collects designated data on substances dispensed in the state. PMPs are housed by a specific statewide regulatory, administrative, or law enforcement agency. In the case of Iowa, we have the Iowa Board of Pharmacy, who actually is housing the PMP, and who you would be calling if you have any issues to get more information or to ask any questions about. Next slide. So what is the PMP, or what is the Prescription Monitoring Program? It's a tool that can be used to address prescription drug diversion and abuse. But, so I say that I want to make sure we're clear that if we look at the functions of the PMP, really it's a patient care tool. And when I go into this, I'm not looking at the PMP because I'm just naturally thinking, okay, this patient's abusing. I'm really trying to put the pieces of a puzzle together on behalf of the patient to make sure that things are being used appropriately. So it becomes a monitoring tool, a patient care tool for us. Is the patient using the medication appropriately? Are they refilling it appropriately? Are they going to other pharmacies? Have other physicians written for this? Because obviously that becomes a medication safety issue if that is the case. It is a tool, though, that can be used to identify drug epidemics in an early warning system. It can help reducing drug diversion, and also an insurance fraud investigation tool. It will help prescribers avoid drug interactions to find out if the patient is taking any other controlled substances. Are they taking any of the opioid type of therapy? Are they taking any other controlled substances that may put the patient at risk of an adverse drug event, such as prescribing a benzodiazepine along with an opioid, which may put the person at more risk of an adverse event. We also can utilize it to make sure the patient is not doctor shopping, nor are they also pharmacy shopping, which, as we know, it does occur. It also could be used by professional licensing boards to identify clinicians with patterns of inappropriate prescribing and dispensing, and it can be used to assist law enforcement officers or individuals in cases of controlled substance diversion. Next slide. So who can access the PMP? We got the prescribers, which include MDs, DOs, we got nurse practitioners, we got physician assistants, we have pharmacists, and then each one of those individuals can designate up to 6 agents per provider who can access on behalf of the provider that information, so that if you're worried about workflow issues, or obviously if you want the physician to focus more on working with the patient and not necessarily having to do this check, they can do that. Same thing with a pharmacist, where they can utilize a technician to do the check from the PMP. So we really want to make it so that it's easy for the office, for the clinic, for the pharmacy to be able to access it, and utilizing agents of the providers to help us be able to access it as well too. What substances are captured in the PMP? It's not just opioids, it's any C2, C3, or C4. I think that's important to know that, because I've got another story. So this will include opioids, benzodiazepines, tramadol, zolpidem, and amphetamines. So anything that will be a controlled substance that says between the C2 and C4 will be captured by this. So earlier this month, we had a patient, and they get a prescription for zolpidem. The zolpidem, normally the highest dose is 10 milligrams every day. In this particular situation, this patient was getting 2 tablets taken every day. It was something that we had been monitoring, something that we had sent recommendations to the prescriber. Eventually, the patient was reduced down or tapered down to 10 milligrams every day. Well, we'll come to find out, when we started looking at this patient, I get a call. Again, it was on a Saturday morning from another pharmacy saying that this patient's coming in and wanting to get a prescription for zolpidem filled, and they saw that they just filled it at our pharmacy not that long ago. That caused me to have some red flags. I went into the PMP, and sure enough, I could see that not only had we filled 60 tablets for this patient, and but then he had gone to another pharmacy earlier, and a few days earlier, and filled another 60, had run that through as cash. And so therein lied the problem, is that we didn't do our due diligence of checking, because we believed it was being monitored appropriately, but even we were caught. So in this situation, the patient had more than double the amount of zolpidem really needed for the time frame that he was using it. when I called the university then on that following Monday to talk to them about it, I found out that one of the reasons why they went back to the 2 tablets or 20 milligrams is because the patient started becoming belligerent within the clinic office, and they just were trying to placate. And so they said fine and gave them the prescription. So obviously not helping the situation, and then just, again, kicking the can down further for the next provider to have to deal with it. So this is something we have talked with the patient about, and that we're monitoring them more closely, that we are using the PMP, and that we got to make sure this patient's using it appropriately. Next slide. What's interesting when you look at this chart and looking at the drugs that are concerned for the C2 through C4s, we can see the semi-synthetic hydrocodone, we can see oxycodone, we also see the tramadol, which is, again, one that wasn't scheduled initially when it first came out, but is a scheduled medication now. So those represent quite a few. But if you really look at the benzos and zolpidem, if you look at those, that represents totally about 25% of this pie. So these patients are probably getting multiple types of prescriptions. That's putting them at further risk of an addiction, and also putting them at risk of an adverse event as well too. So we just need to be aware about what our patients are doing, how they're using it, and what we can do to help them better manage it. Next slide. Iowa, if you look at this map, Iowa is not a state that mandates registration with the PMP, nor does it mandated that a provider or a pharmacy has to actually look at it. Now, that might change in the future, because you can see the number of states for which it is required for prescribers to register with the PMP, and that it needs to be checked before dispensing an opioid prescription. But it goes back to that situation that I mentioned earlier, that are we at increased risk because this tool does exist, and if we're not utilizing the tool on a proactive basis and using it to really appropriately monitor the patient, but to really identify the patient who may be at risk before even prescribing it, is that putting us at increased risk? Is that making us at increased liability for prescribing or dispensing this medication? So this tool is out there. I do believe this tool now, from my perspective, is the standard of care. If we're not doing the standard of care, is this something that's going to come back to haunt us as providers by not utilizing it as effectively as we can? Next slide. So this question is the PMP a privacy violation? Obviously, the Board of Pharmacy wants to make sure that patients' privacy is being protected and is of utmost importance. So I can't just freely, give this to anybody, a report. And so there are some rules that we have to follow to make sure that we're protecting the information. So we want to ensure that the patient's information is protected at all times. So if law enforcement comes into the pharmacy saying they want this data, if they're doing an active investigation, we cannot give that to them. What we can do is refer the law enforcement agency to the Board of Pharmacy, who can then, through whatever they have to do from a request perspective, can give the information to the law enforcement agency. Healthcare providers can access the PMP only for data relevant to their patients. One of the questions that have come up in the past is that if I have a physician who has not checked or does not or is not routinely checking the PMP, can I share the information with them from the PMP that we have? In that situation, we can do that as long as it's a shared patient, it's a mutual patient. Again, what we're doing is making sure that both providers are on the same page to appropriately assess the patient, appropriately monitor the patient. So sharing of a PMP report, any healthcare provider actively involved in the patient's care. As I said, it cannot be released. I can't even release it to the patient, because we've had some patients who challenge us saying, first they didn't even realize there was a PMP. And I think part of our responsibility is we're working with patients saying there is a tool out there. I'm not afraid to tell them about the tool, about the PMP, but I cannot give them the report. If they really want to see their data, they can actually go to the Board of Pharmacy. I can give them the information to go to the Board of Pharmacy. They can call and they can get their own report at that point as well too. Next slide. What I think is important is to understand that the PMP is effective. And as I put this presentation together, a year or so ago, I looked at some of the studies that were out there about the PMP. And it's not so much that these are robust, standardized type of studies, but it is showing from a case example that they are effective. So in the first bullet, it talks about the PMP and in an emergency room, and that they had 41 cases where when the physician or the prescriber actually looked at the PMP, it altered their prescribing. 61% of patients received fewer opioid medications than had originally been planned because the PMP indicated a potential issue. So obviously by utilizing it, again, you can identify a problem before it becomes a problem. Then in the next bullet, it's actually a state, Kentucky, when they used their PMP called Casper, and they found that 90% of those surveyed believed that using the PMP was effective in preventing drug abuse, diversion, and doctor shopping. So then from a statewide perspective, overall, people felt like it did a good job of helping to identify patients who might be potential issues. And then the last bullet was we're looking at several states and saying that utilizing the PMP did reduce unwarranted prescribing and subsequent diversion of abuse prescription drugs within their states. So again, the information is out there. We got to utilize it effectively, and hopefully by utilizing it, we can make sure that our patients are utilizing the medications appropriately. Next slide. So benefits of the PMP, it supports access to legitimate medical use of controlled substances. We can identify and deter or prevent drug abuse and diversion. Again, identifying the issue as it's emerging or hopefully before it's emerging, but try to be proactive. It will facilitate and encourage the identification, intervention, and treatment of persons addicted to prescription medications. As we update the PMP, which should be coming out in April of 2018. There'll be a tool on there, which we'll talk about, which will further help us to provide solutions for that patient we've identified at high risk. Because I know that the concern we have is, what do we do with these patients? Well, it is our responsibility as healthcare providers to make sure our patients are getting to the appropriate places they need to go to make sure that they're taking care of the problem that they have. We want to inform public health initiatives to outline the use and abuse of trends. And then also it's used to educate individuals about PMPs and the use, abuse, and diversion of and addiction to prescription medications. Next slide. Myths of the PMP, it is not difficult to register, and we'll see that as we look at subsequent slides. It's a very simple process and easy to find. Just go to the link, which will show. It is not difficult, nor is it time consuming. Literally, you could take just 2 to 3 minutes once you have the information and you know how to actually navigate the PMP. It's a very quick process. Last bullet says, I don't have time to check the PMP. Well, yes, you do, and I think we have to make time, but also remember that we can utilize up to 6 agents within our practice to check the PMP and maybe provide the reports for us before we actually see the patient or talk to the patient. Next slide. So challenges, as I said, not everybody's utilizing this. I'm hoping with these kind of programs that we're having, it makes people more aware about the importance of using it. But there is a potential gap between reporting when information is entered, and I think hopefully with time as systems become better and information is uploaded more real time, that will go away. But right now there's up to a 2-week lag time after the dispensing of the controlled substance before it will actually show up. That actually occurred with that oxycodone patient where they made reference that they filled something a week before. That was not actually in the PMP yet, so he actually provided me with more information of the reason why I wasn't going to fill it for him based upon that information as well. If there's an error in the prescription record, that error has to be corrected before processing, before it gets processed in the PMP. So most of this is done automatically by vendors, so it's probably done behind the scenes. You're not seeing it. Next slide. Future of the PMP, as I said, they look like they're going to be updating this, and hopefully by April of 2018 we'll have it. It'll be more user-friendly. It'll be easier to pull data. It'll be more within the workflow. And then NarxCare is the tool that I was talking about that I'm excited about. I don't know much about it, haven't seen it, but I've read about it. And it will help to identify those patients who might become high risk or who are high risk. It will also provide tools and resources to help work with that patient. It will also identify medication-assisted treatment centers that might be close by if we need to refer a patient. So it's just an overall, I think, an extra tool that will be very beneficial to help our patients who might be at risk. Next slide. So quickly we'll go through utilizing the Iowa PMP. Next slide. So as we look at the actual registration, if you go into it and if you're not registered, all you'd have to do is click on the left-hand side there, and you can actually contact the Board of Pharmacy, and they will help you to register as well too. But once you register, you're going to get a username and a password. All you do is put that in. If you forget the password, which happened to me when I got a new computer because it wasn't saved in the new computer and I didn't write it down, I actually had to call the Board of Pharmacy. With a new upgrade that they're talking about in 2018, hopefully you can get the new password just electronically and not have to call someone, which you do have to do today. Next slide. So as we look at this is what happens when you actually log in. If you click again, it will say My Account. Go ahead and click. This will give you information about your account. If you need to update it, you can do that. Next click. This area here is any messages that might be out there or alerts that for you to look at, so you can see if there's already been something posted out there. Next click. This is where you actually will be putting information in where you want to actually look at a patient. You'll do a request, or if you want to put an alert about a patient. Next click. And then if you have a question, you have a question mark on the right-hand side, and click on that to give you some help with it as well. Next slide. This is the actual, when you do the request, you will put in the patient's last name, first name. You can see anything that has the red asterisk is absolutely needed information, so you're going to need that, and birth date. So first name, last name, and birth date. It will actually default to 12 months. You can actually put a higher date range, in which we have done that. And if you look at the states that are involved, you see the ones listed there: Illinois, Kansas, Minnesota, South Dakota, Wisconsin. Other states involved now include North Dakota. We've got Maine, we've got New York, and can't remember the last one, but there's some other states as well too. I got North Dakota, New York, Maine, and Montana is the other states. Next slide. So you'll put the information in, and then this screen will pop up and it'll say Attachment Patient RX History Report. You will actually click on that, and that will actually print out or actually provide you with a PDF summary of their prescriptions. There's controlled substance prescriptions. Next slide. If you submit it and it doesn't come through, you'll get this response: your request results exceed anyway, the threshold value. The request has been submitted for manual process. In that situation, you don't resubmit. You call the Board of Pharmacy. They'll provide you with the information that you need. But otherwise, if it's there, you just have to click on that patient RX history report in a PDF format, and it will provide that for you. Next slide. And that's what this report looks like. So in this particular test case, we can see the patient, what they have filled, what the dates were they filled it. Obviously, for those patients who really are problem patients who are overutilizing, it will be an extensive report. It may take you some time to actually kind of sort through where they're getting things filled, who are the prescribers, the frequency, the dates, and kind of putting the pieces of the puzzle together. So although access will be quick, sometimes reports, even if it's just a time frame of 12 months, will be pretty extensive if the patient's going to multiple places. If you add those other states in, you may get even a bigger report. So it is something that may require, but at least that will give you information that you may have a potential problem for which you don't want to prescribe an opioid. Next slide. The Board of Pharmacy has a PMP user guide to assist in learning how to use the PMP. And as I said, with the new update, we're hoping that that will even simplify things further, but this is the actual link for you to get the user guide. Next slide. So in summary, the PMP is a tool to prevent addiction, diversion, and doctor shopping. It's easy to use. It's easy to register. As we said, we can now utilize up to 6 agents to assist in looking up PMP information. But if you have any questions, you can always review the PMP user guide. And with that, Sarah, I think we can open it up.
Perfect. Thanks, Randy. We will open up for questions here shortly. I do want to thank Randy for his time and his expertise on this. I know you've always got a new story every time I talk to you regarding opioids or the PMP. So thank you so much for taking the time with us. This is just a list of our upcoming webinars. I only have the next 4 listed on here. So on February 15th, we will be launching our pain to comfort resources. On February 15th, we'll have more information on that. February 28th, we will do our Train the Trainer on how to actually do a community meeting. And then on March 15th, we have our Upstream Prevention Tools and Best Practices, which again will have nursing contact hours if you're interested in joining that webinar. And all of these are at 11 a.m. I do have our contact information up here. If you'd like to reach out to Randy, myself, or Jennifer on any of this, you are more than welcome to do so. And with that, Randy, we've had a couple of questions come in. Some that I'm not sure that either of us can answer, but that's okay. We can get the answer for them at a later time. So our first question was, are scripts that are paid for in cash uploaded to the PMP?
Yes, they are. So whenever we fill a prescription, any controlled substance prescription is uploaded into the PMP. So you will actually see that when you go into the PMP. It will have if it was cash, if it was insurance. I think a lot of times patients think that, okay, I can bypass the whole system if I'm paying cash, but it does not bypass it. That data is being pulled by our vendors. Doesn't matter if you paid cash or not, it's uploaded into the PMP.
And our next question is, can a PMP report be scanned into the electronic health record?
There's probably absolutely no reason why you can't do that. We actually scan it up into our record. Again, as long as you've got the safety features in there, which with any electronic medical record, you probably should anyway, right? So as long as the patient's data is safe and secure, there's absolutely no reason, because if you're utilizing it as a way to monitor the patient and to ensure that any other provider who's going to be working with that patient has access to that, there should be no reason why you can't do that. It's just how you share it. It needs to be specified that it has to be shared with providers who are actually taking care of that patient. So that's the main thing.
Yeah, and I would just add to that, from the Board of Pharmacy, our understanding is that we shouldn't be scanning it into the electronic health record, but we should have some sort of way to say that the PMP was checked. And I think the reason for that is kind of similar to the mental health concerns, where we have extra barriers to get into that record with the mental health, and they don't want to have that circulating necessarily in an EHR. But yes, you should have something in there that you're checking. Yes, we've checked the PMP, or we have concerns. You can write in your note, we have concerns about this from the PMP record being checked. So I can double clarify with that with the Board of Pharmacy and make sure that that is correct and get back to that person that asked that question.
And Sarah, I appreciate that too, because obviously, there's always this gray area with the board, and that's why I always struggle with the board, right? Gray area. I think this could be a gray area. For us, it's just being kept within the pharmacy. And so it's just us who are accessing it. So that's a good point to make. Thanks.
Yeah, I think that's a really good point, Randy. Our next question was, what is the reason for only allowing 6 agents per registered pharmacy or pharmacist or physician? So why can they only have 6 agents? And honestly, I don't have the answer to that question. I would have to clarify with the Board of Pharmacy why they chose only 6.
Yeah.
I don't know if you have any insight on that, Randy.
I don't have any insight, but it was increased from 4, right, to 6.
Right.
And I think part of it's just management, right? The more people have it, you want to make sure that things are being done appropriately, and people cannot just be accessing the record just to be accessing it. So I think part of it might be a management, but I can't give you specifics. But we were fortunate they increased it from 4 to 6.
Yeah, and I think that's a big piece of it, and a good point is that management piece, but it is per physician or per prescriber or per pharmacist. So I know the person that asked this question mentioned that they work in the ER, and so it can be very helpful for them to have the PMP access, but there's a lot more than just the people that work in the ER. So I think that's a key point too, is that if you have frequent nurses or medical staff that you're working with when you are in the emergency room, you can have up to 6 people that access it based under your registration and your information within the PMP.
Correct.
Our next question, let me scroll here for just a second. So we had a question, will you be emailing those webinar dates and registration links out soon? If you are part of our opioid guardianship project, you should have already received all of those dates and the registration links. We will make sure to get that out to anybody that is interested. You can also email Jennifer or myself and work with whoever is the owner at your hospital for the opioid guardianship project to get those dates and registration links. If you are not part of our project, please feel free to reach out to Jennifer or myself, and we can get more information to you on the webinars. Our next question is, how long will this webinar be available for review? So it will be up in about a week or two once we get it all transcribed, and it will be on both Innovation and on our YouTube link. And I don't think we're necessarily pulling that down. So it should be up for at least 6 months, if not longer, for you to go ahead and take a look at if you're interested. And then, having some technology things here. Hold on just a second. Okay, so those are the main questions that I think we had come in. I had one question for you, Randy, and you may have covered this, but with law enforcement, you mentioned that that's not something we can just hand over to law enforcement. If we did have a police officer or somebody come in and ask us for a PMP report, who should they contact in order to get that information?
So if you go to the PMP website, you'll have a phone number to go to. It's usually Terry Petoskey from the Board of Pharmacy. That'd be probably the key person, but there'll be a number for you to call for the Board of Pharmacy. That's who you would talk to.
Perfect. And then we did have another question. How do you sign up an agent if you want to have an agent access the PMP?
That's going to change too with the new, and the way you do it now, it has to be by paper. So you literally would have to call the Board of Pharmacy right now and say you want to have an agent for the provider, and they would, give you access to the paperwork, and you'd fill that out. In April, what the discussion has been that the new PMP, that process will be automated just like it is for us as providers. So I'm hoping that will simplify it. But right now, yes, you have to actually call and get access to the form for you to fill out.
Perfect. Thank you, Randy. I think that's all the questions we have that have come in so far. If you do have a question, feel free to go ahead and add it into the chat box. I do want to add that we will have Jennifer, Tiffany, or somebody else from the Board of Pharmacy on a webinar once the new PMP is available, so we can walk through kind of how to use it, the new functionality. If there's any kind of key pieces that you need to know about as a prescriber or pharmacist, we will have somebody on there to discuss that probably in April. But as soon as the PMP is available, we'll make sure to get a webinar out, and that will be a separate registration that you have not received yet. I do want to thank Randy again for his time today. Your insight on this is wonderful, Randy, and I think we've got a great group on that had a lot of great questions, and we'll continue to take those questions. If you'd like to email Jennifer or I, we can get those answered for you if we didn't get to it today. And I do want to thank you all for joining us for today's webinar. Again, our next webinar will be February 15th to kick off our comfort resources. If you did want to get contact hours, the nursing CEUs or contact hours as they're termed now, you did need to be logged in for the entirety of the webinar, and we will get that information out to you soon along with an evaluation. Otherwise, those who are non-nursing will receive a certificate of participation in the next couple of weeks. Thanks again for joining us, and I hope you all have a great day.